Hey, good afternoon, everybody. We're going to go over today again, as we've done before, but it's just so important to memorize these rules to get them so it's intuitive. You don't have to think about it. We're going to review again the 6 clinical acid-base rules and how to use these when you're making a diagnosis. And if you can master these and they become something that you just know off by heart, you'll be able to make a diagnosis in any patient. So I wanted to just reiterate a few concepts, and that is that a single acid-base disorder is sometimes called simple, but it just means that you don't have more than one present. And I wanted to bring up the other point, and that is if the total CO2 or bicarbonate is decreased in a simple acid-base disorder, no matter what it is, whether it's metabolic acidosis with a low total CO2, or whether it's acute respiratory alkalosis with a low total CO2 or bicarbonate, or chronic respiratory alkalosis, the PCO2 is also decreased. So in the simple acid-base disorders, whenever you have a change in the bicarbonate in a certain direction, the PCO2 is always in the same direction. That's a real clue, because if they're in opposite directions, you don't have a simple acid-base disorder. It's very important to recognize that as a pattern initially. So again, if the bicarbonate's down and it's a simple or a single acid-base disorder, the PCO2 must also be decreased in the same direction. And conversely, if the total CO2 or the bicarbonate's increased, then if it's a single or simple acid-base disorder, the PCO2 is also increased. If the PCO2 is in the down direction, when you have an elevation in your bicarbonate, you don't have a simple acid-base disorder. So again, we have 6 acid-base disorders, and in the down direction, we have 3, and in the up direction, we have 3. But in both the down and the up, there's a down for bicarbonate and a down for PCO2 in one of these 3 acid-base disorders. And if the bicarbonate or total CO2 is up, the PCO2 is increased in these 3 acid-base disorders. So you have to have that sort of model in your mind when you're approaching the patient. And now, once you really can intuitively understand that, you then use the acid-base rules to distinguish which of the 6 it is, or we subdivide it into which of the 3 it is, because you've already broken it down into 3 and 3 based on the direction. So I thought I would go backwards today and just again try to make your minds memorize what the acid-base rule is. So we're asking sort of backwards now. So if you see a change in the bicarbonate and the change in the PCO2 in the ratio of 1 to 1.2, so in other words, the bicarbonate changed by 1 for every 1.2 change in the PCO2, which of these 6 acid-base disorders is it? Now, I'm not even giving you the direction, because of the 6, this only occurs in the down direction for both. So once you memorize the rules, not only will you know that there's one rule where you have a change of bicarbonate of 1 for every change in the PCO2 of 1.2, but they're both in the down direction. You never see this kind of thing in the up direction. So does anyone want to pick which of the 6 acid-base disorders you see a change of 1 to 1.2? Anyone want to unmic? Again, you need to memorize this for your boards. Sorry, go ahead. Anyone? This is what you see in metabolic acidosis. So in a compensated metabolic acidosis, for every 1 change in the bicarbonate, the PCO2 changes by 1.2. That's the rule. It's empirical. There's no there's no reason for it that you could predict mathematically. It's just the way human beings respond to a drop in their bicarbonate. Their PCO2 changes a little more than the bicarbonate change. So if you see this, patient has a metabolic acidosis that's compensated. So please start memorizing these rules. There's 6 of them. Okay, what if you see a patient where the change in the bicarbonate was 5 for every 10 change in the PCO2, or in other words, 1 to 2. So the PCO2 changed twice as much as the bicarbonate changed. Does anyone know which of the 6 acid-base disorders you see this in? So it's not quite 1-to-1 like compensated metabolic acidosis. And again, once you memorize these, you will immediately recognize you only see this ratio in the down direction also. You don't see this in the acid-base disorders that increase the bicarbonate. So does anyone know which acid-base disorder you have
So
quite much change in the PCO2 as the bicarbonate?
would it, I'm guessing it's either for chronic respiratory alkalosis or acidosis. I guess alkalosis between
Yes,
the.
this is the empirical rule that people have seen in women who are pregnant, or in chronic liver disease, or in people who live at high altitude. They all have a chronic respiratory alkalosis, and they all have a change in the PCO2 that's twice whatever the bicarbonate changed. So yes, this is what you would see in chronic respiratory alkalosis. Okay, what about this? A change in bicarbonate to change in PCO2 of 3.5 to 10. Again, once you learn these things, you will see that this only occurs in the group of acid-base disorders where the bicarbonate increases. You never see this ratio in the down direction. So does anyone know what acid-base disorder you see this ratio in? For every 3.5 change in bicarbonate, the PCO2 has.
Acute respiratory acidosis.
No, this is chronic respiratory
Oh,
acidosis. Yeah. So in chronic respiratory acidosis, the chicken is the PCO2 and the egg is the bicarbonate. For every 10 increase in the PCO2, the bicarbonate goes up by 3.5. So the change of the two of them in proportion to each other is not quite as great as in chronic respiratory alkalosis. In chronic respiratory alkalosis, the bicarbonate changes by 5 for every 10 change in the PCO2. And again, you just have to memorize it. Okay, what acid-base disorder do you see this kind of ratio? For every 2 change in the bicarbonate, the PCO2 has changed by 10. And again, I'm not giving chicken and egg here. If I did, I would give away the group of the acid-base disorders. So it's better to recognize these ratios without learning direction and without learning what the chicken and what the egg is. Did the change, in other words, when I say chicken and egg, I mean, did the change in the PCO2 initiate things and then you got a secondary change in the bicarbonate? Or did the bicarbonate initiate things and your PCO2 came afterwards? You don't need to know that, although if I did give that clue, it would make it easier for you to give the right answer. It's better just to memorize the delta bicarb to delta PCO2 for each of them. Since they are all different, you'll never mix up. They all have a different ratio, each of the 6. So which one has a change in bicarbonate to change in the PCO2 of 2 to 10? And again, I'm not specifically saying here whether the bicarbonate changed by 2 and that caused the PCO2 to change by 10, or whether the PCO2 changed by 10 and that caused the bicarbonate to change by 2, nor am I saying whether the bicarbonate increased and the PCO2 increased, or the bicarbonate decreased and the PCO2 decreased. Just the ratio itself, just the value of that number should be able to give you the diagnosis. Anybody? Well, this is what you see in acute respiratory alkalosis. And the chicken is the PCO2, the egg is the bicarbonate, and they're both in the down direction. So for every 10 decrease in the PCO2, the bicarbonate falls by 2. And remember, that doesn't require an organ. That's what occurs when you open a bottle of Coca-Cola or open a carbon dioxide buffered solution to air. When you have an open system, the bicarbonate falls because it's in equilibrium with the carbon dioxide in that buffer reaction. You don't need a kidney for this to occur. But what happens if you keep the PCO2 down by 10 for a number of days, the bicarbonate falls further such that the total fall, as was mentioned before, is 5. So the total fall is 5. It's 3 above the acute. So remember, for chronic respiratory alkalosis and chronic respiratory acidosis, it's above what already occurred for the acutes. It's an important point. It's not some total new phenomenon. You superimpose an additional effect on what already occurred acutely. So for chronic respiratory alkalosis, the acute causes a bicarbonate to fall by 2. And then if you keep the PCO2 down for a longer period of time, it falls an additional 3. Okay, what about this ratio? Which of the 6 acid-base disorders do you get this ratio in? Again, I'm not giving away the direction, and I'm not giving away which is the chicken, which is the egg. And again, you don't need it. You don't see this ratio in anything other than one acid-base disorder. Anybody know which acid-base disorder the bicarbonate changes by 10 and the PCO2 changes by 7 from its original value? Well, this is what you see in metabolic alkalosis, compensated. So for every 10, and the directions are up, and the chicken is the bicarbonate, the egg is the PCO2. So for every 10 increase in the bicarbonate, the PCO2, you decrease your ventilation such that the PCO2 goes up by 7. Okay, so same sort of concept as in metabolic acidosis. There's a respiratory compensation. Remember, we only use the word compensation in metabolic acidosis and alkalosis. We do not use the word compensation in acute respiratory alkalosis, chronic respiratory alkalosis, acute respiratory acidosis, or chronic respiratory acidosis. We don't use the word compensation in the respiratory acid-base disorders. We have a temporal distinction, acute versus chronic. Okay, this is another ratio. Bicarbonate changed by 1 and the PCO2 changed by 10. Which acid-base disorder do you see this in? Well, this is acute respiratory acidosis. So for every 10 increase in the PCO2, the bicarbonate goes up by 1. Again, it's just what would happen if you bubbled an aqueous solution with carbon dioxide. If you keep the PCO2 elevated longer than just a few minutes, then the bicarbonate in the body, this requires a whole body, the bicarbonate will continue to go up such that the total increase was 3.5. So it goes up another 2.5 above that. And in between, it's going to be in between. So if in a very short period of time, over minutes, the bicarbonate will go up by 1. But if you keep the patient at an elevated PCO2, if you did it in a beaker of water on the table, it would stay at 1. But in a mammalian body, it goes up another 2.5, so that the total increase is 3.5. That requires a kidney and a number of other things occurring in the kidney to generate and reclaim that additional new bicarbonate. Okay, so let's go through those again from the beginning. Just to reiterate, in a single or simple acid-base disorder, the direction of the changes of both is the same. If they're in opposite direction, it's not a simple acid-base disorder. It's mixed. And that occurs both in the up direction and the down direction. They have to be in the same direction if it's simple. If it's down for both, it's one of these 3. If it's up for both, it's one of these 3. The way we distinguish which of these it is you memorize those 6 ratios. So if the ratio is 1 to 1.2, it's got to be compensated metabolic acidosis. You don't need to know the Winter's formula. If it's a change of 5 to 10, it's chronic respiratory alkalosis. If it's a change of 3.5 to 10, it's chronic respiratory acidosis. If it's 2 to 10, it's acute respiratory alkalosis. If it's 10 to 7, it's metabolic alkalosis compensated. And if it's 1 to 10, it's acute respiratory acidosis. So that's it. It just requires sitting down and memorizing it. And that will allow you to diagnose any simple acid-base disorder. And realize also we have not looked at the pH. We've done this without caring what the pH is. Okay, so that's the approach on your exam. Now let's go through the time it takes. So which acid-base disorder takes 11 to 24 hours until you've reached a new steady state after the initiation? Anybody? Okay, that's what you see in metabolic acidosis. So if I drop your bicarbonate with lactic acidosis or ketoacidosis or a hydrochloric acid infusion, it'll take about a half a day to a full day until your PCO2 reaches its new limit of 1.2 times whatever the bicarbonate fell by. Okay, it doesn't occur immediately. The respiratory compensation takes half a day to a day. Be careful about that, because if you see the patient in between the initiation of the event and the new steady state, you're going to think that there's a mixed acid-base disorder. But as I was mentioning last time, you just haven't waited long enough. So you've got to wait long, and you've got to know how long it takes to reach the final values before you start interpreting the numbers as being compatible with a mixed acid-base disorder. Okay, which acid-base disorder takes a day to a day and a half? That's metabolic alkalosis. So if I start vomiting, or I start Lasix, or whatever the cause of the metabolic alkalosis, my PCO2 will start to go up, but it takes a day to a day and a half till it stops changing, till it goes up 7/10. Remember that 10 to 7 ratio. It takes about a day to a day and a half until that PCO2 stops going up any further and I reach a new steady state. A little bit longer than metabolic acidosis compensation. Okay, which acid-base disorder takes 3 to 5 days to reach a new steady state after its initiation? That's chronic respiratory acidosis. Remember, the acutes are minutes, so we don't really need to specify those. But chronic respiratory acidosis, so if I change the vent settings and raise your PCO2 from 40 to 60, it's going to take 3 to 5 days until your bicarbonate, which will start going up, stops changing and reaches a change of 3.5 for every 10 increase in the PCO2. That takes 3 to 5 days. It's quite some time. And 2 to 3 days is chronic respiratory alkalosis. So if I suddenly hyperventilate you, it'll take 2 to 3 days for your bicarbonate, which starts to fall, to stop falling. So you need to know these temporal components, because if you don't, you're going to think that the patient has a mixed disorder if you come in between, prior to them reaching a new steady state. Okay, so let's go over those again. Compensation for the metabolic acidosis takes half a day to a day. Metabolic alkalosis takes a day to a day and a half. Chronic respiratory acidosis takes 3 to 5 days until the bicarbonate stops changing. The PCO2 has changed instantaneously. We're not talking about a dynamically changing PCO2. We're doing an experiment here where we had a PCO2 of 40 and we step changed it up to 60 immediately. And now we're tracking the bicarbonate over each day as we measure it, either with venous gases or the total CO2. We would find that the total CO2 or venous bicarbonate or arterial bicarbonate keeps going up and up and up until after 3 to 5 days, it stops changing. That's when we've reached the new steady state. And that's when we say the patient has a chronic respiratory acidosis. Whereas chronic respiratory alkalosis, we step change the PCO2, let's say from 40 to 20. And now we watch over the next number of days, the bicarbonate falling until a new steady state is reached. That takes 2 to 3 days. Okay, so here's a patient, 58-year-old male who was vomiting, dysnatremia, hypokalemia. The total CO2 is elevated. Looks like there's some pre-renal failure. And the PCO2, which is probably on a volume depletion basis, and the PCO2 is 47. The bicarbonate is 35. Remember, the bicarbonate on the blood gases is calculated from the pH and the PCO2, which are measured with 2 electrodes. I've left out the pH here just to keep reinforcing over and over and over and over and over again, as many times as I can say it. You don't need the pH to make an acid-base diagnosis, nor should you use it, because you're gonna, if you do rely on it, you're gonna miss mixed acid-base disorders. So I purposely left out the pH here. So the PCO2 is 47, the bicarbonate's 35. And the question is, first of all, what is the delta bicarbonate to delta PCO2? Well, in any patient, to do that, you have to know what the original values are. We typically don't have that, so we use population means. Males and females are different, so we use population means. For a male, PCO2 is typically 40, the bicarbonate's 24, 25. So what is the delta bicarb to delta PCO2 here? You take the 40 and you subtract that from 47. You take the bicarbonate of 25, you subtract that from 35. So the bicarbonate has changed by 10 and the PCO2 has changed by 7. The question is then, what is the acid-base disorder where you get that ratio? And as I said before, it's a compensated metabolic alkalosis. And when you see this delta 10 to delta 7, that's all it can be. So again, it must be a metabolic alkalosis that's compensated, because the PCO2 has gone up 7 for every 10 change in the bicarbonate. Anyone have any questions about that? So again, no pH. Look at your deltas and see which of the 6 acid-base rules your deltas fit into. That's what you check off on the exam. And it's compatible with the vomiting too. You can go back and say, well, this is what mathematically I think the acid-base disorder is. Is it compatible with the clinical situation? And the answer is yes. There's no other acid-base disorder that vomiting is going to lead to, at least simplistically. Okay, so the same sort of thinking here. 27-year-old male, dysnatremia, the total CO2 is 30. The total CO2 is 15. Again, it looks like there might be some AKI or something going on here, maybe pre-renal, hard to say. The glucose is elevated, so we're thinking, well, the total CO2 is down, maybe there's ketoacidosis here. Check the anion gap, and you can see here that the anion gap is elevated. And the PCO2 is, again, no pH on purpose, I left it off. The PCO2 is 27, bicarbonate's 14. Again, we don't have original numbers, but we'll assume that the PCO2 was 40 and the bicarb was 14. So the PCO2 has changed by 13, right? 40 minus 27 is 13. Bicarbonate's changed by 10 or 11. So we have a ratio of about 1.2 to 1 here. And again, we just go back to the 6 acid-base ratios and try to remember which of the 6 this fits in with. And again, it's fitting in only with a compensated metabolic acidosis, where the change in the bicarb of 1, you expect a change in the PCO2 of roughly the same, a little bit more, 1.2 to 1. Again, we don't need the Winters formula. And again, that is compatible with what the patient has clinically. They likely have a metabolic acidosis. It's organic anion base from ketones coming in with a proton. And the change in these numbers here is compatible with a compensated metabolic acidosis. Remember, it had to have been present for at least half a day to a day for this ratio to fit, because it takes that long for the PCO2 to change from 40 down to 27. If you came after a few hours, the PCO2, let's say the patient got ketoacidosis, dropping the bicarb to 14. Initially, the PCO2 may be 36, 37, but if you keep following the PCO2 over that day, eventually after maybe half a day, but certainly by a day, the PCO2 will have steady stated out. Now, in the real world, obviously, things are more dynamic. The bicarbonate may be continually changing, so you reach sort of pseudo steady states. It's a little bit more complicated, but assuming that we have a simple input of protons here, and the bicarbonate has stayed at 14 for at least a day, day and a half, the PCO2 should steady state out at around 27. So these numbers are compatible with a compensated metabolic acidosis. And what you can also infer is that the patient's ventilatory system is normal. It's very important too, because if this is telling you that the patient is hyperventilating, what they should be doing, if the ventilation, if the PCO2 is 34, 35, 36, it isn't just that they haven't compensated properly, but they are also not, it tells you they're not ventilating properly. And thirdly, they have to have another acid-base disorder present, which is a respiratory acidosis, even though the PCO2 is 32, 33, it should be 27. So there's a lot of subtleties here in the diagnosis also that you should be aware of when you're with the patient. Okay, so again, the changes are 1 to 1.2. The only ratio, the only acid-base disorder that's compatible with is a compensated metabolic acidosis. Okay, so again, please memorize these ratios. Okay, here's another patient. And what you see here is there was an anxiety episode. You might start thinking maybe right away what might be going on. But again, the same sort of thinking. No, I left out the pH on purpose. The PCO2 is 20, the bicarbonate's 21. Again, we calculate the ratios. So the PCO2 fell by 20, the bicarbonate fell by 4. So that's about 2 to 10, or 1 to 5 if you want. And you can memorize these things any way you want. But the point is, for every 10 change in the PCO2, the bicarbonate changed by 2. Here, the PCO2 changed by 20, so the bicarbonate changed by 4. So again, there's only one acid-base disorder that has these kind of changes, or the ratio of 2 to 10 or 1 to 5, whatever you like memorizing. And it's shown here. Acute respiratory alkalosis has these kind of changes. Remember, chronic respiratory acute respiratory acidosis is 1 to 10. They're a little bit different. Okay, so again, we go back to the clinical side of things, and it's compatible with just the anxiety episode. Assuming it was acute, you wouldn't expect this to be different from what you would expect in the acute acid-base disorder setting, where it took minutes to occur. Now again, if the patient had this anxiety episode for longer than just a few minutes and it lasted days, then with the PCO2 of 20, this bicarbonate would continue to fall further until the ratio was 5 to 10. So that, in other words, or 2 to 1, where the PCO2 fell twice as much as the bicarbonate fell. So the bicarbonate would fall an additional amount such that this fell by 20. In other words, we're not changing the PCO2. We just keep it at this new low level of 20, but the bicarbonate will continue to fall until it fell to about 15. So this initial fall is just what you would expect if you opened up a bottle of soda water. The further fall over time is requires organs, requires the whole body and the kidney. Now, if you have ESRD, that's another subtlety. It's always going to look acute. So a patient with ESRD who hyperventilates, their acid-base disorder is never going to look chronic because the bicarbonate can't fall like it does in a normal kidney. It'll always look acute. And the same is true of chronic respiratory acidosis in an ESRD patient. If you have someone with COPD, chronic bronchitis, and they have an elevated PCO2, chronically, their bicarbonate's not going to go up 3.5 for every 10 increase in the PCO2. It's going to stay increased by 1 because the kidney can't generate and reclaim that new bicarbonate. So you can get fooled if you don't know the clinical context also. So again, these numbers are compatible only with acute respiratory alkalosis. Okay, here's another patient, 60-year-old male. Again, I left out the pH on purpose. And the total CO2 is 38, PCO2 70, bicarbs 36. Again, we just calculate those ratios. The PCO2 has increased by 30, and the bicarb has increased by about 11 or so. Again, we don't know the original numbers, so these deltas are a little bit approximate, and we have to use what the population normal numbers are. So again, 30 change here, increase, and this is up by 11. So it's roughly 3.5 to 10. Again, there's only one acid-base disorder that you see this in, and that's chronic respiratory acidosis. Okay, so for every 10 increase in the PCO2, the bicarb will go up by 3.5. If the PCO2 goes up by 20, from 40 to 60, this will go up by 7. If the PCO2 goes up by 30, as in our patient, this will go up by about 10.5 or so. And another subtlety here is you can see that there's a little bit of an increased difference between the total CO2 and the bicarbonate. Remember, the total CO2 is made up of bicarbonate plus dissolved carbon dioxide, and the dissolved carbon dioxide is 0.03 times the PCO2. Okay, so 0.03 times the PCO2 is 2.1. So 2.1 millimoles per liter of that total CO2 is not bicarbonate. It's dissolved carbon dioxide. 0.03 is the solubility coefficient of carbon dioxide. In other words, the solubility coefficient tells you how much of a gas gets dissolved in solution. So forget the units, it doesn't matter. But for carbon dioxide, it's 0.03. So to answer the question, how much of the total CO2 is not bicarbonate, you just take 0.03 times your PCO2. Normally, it's like around 1.2, because the PCO2 is around 40. But as you raise your PCO2, you have more of the total CO2 dissolved carbon dioxide, and you'll see in the patient, you get a bigger difference between your bicarbonate on your blood gases, which is only bicarbonate, calculated, but only bicarbonate, versus the total CO2, which includes dissolved carbon dioxide. So that's what you would expect. Okay, so again, we calculate a 3.5 change for every 10, or if you want, a 10 change, roughly a 10 change for every 30, and that's only compatible with chronic respiratory acidosis. Okay, so I think I'll stop there for today. What I wanted to do is to, again, reiterate the need to not look at the pH. Just don't do it, or you're going to never be able to achieve the ability to diagnose mixed and simple acid-base disorders without mistakes. Memorize the 6 rules. It's pattern recognition, like it's a Rorschach test, just like looking for subepithelial deposits on a renal biopsy to diagnose membranous nephropathy, the same sort of thing. Just memorize those ratios and then answer the question, does my patient have those ratios? Which one is it? And that'll give you the acid-base diagnosis. But remember the subtleties, that there's a temporal component, and you have to remember that these things take time. Again, compensated metabolic acidosis takes a day, roughly half a day to a day. Metabolic alkalosis takes a day to a day and a half for the PCO2 to reach its final steady state. Chronic respiratory acidosis can take up to 5 days till the bicarbonate stops changing after you've initiated a change in the PCO2. And in chronic respiratory alkalosis, it can take 2 to 3 days. So remember that, because if you come in between, you're going to think there's a mixed acid-base disorder, even though there isn't. So I think I'll stop there for today. And does anyone have any questions at all? Okay, well, I hope that was clear, and have a great day, everybody. Talk to you next week.